Thank you for investing a few minutes to learn more about lean patient flow solutions. We'll cover an overview of what Expediter has learned about the topic over the last 34 years. Our goal has always been about helping practices streamline and optimize their patient flow. Our value proposition is very simple. Expediter applies lean management principles to increase efficiency in patient flow, which results in better quality of care and higher patient satisfaction. The core of the solution is a highly customizable light signaling system that enables a practice to streamline communication, increase efficiency, increase revenue, and build a more satisfying office environment. The function and value of many of the features of the Expediter light signaling system can be viewed at our YouTube channel called My Expediter System. Take a look there to learn more about the details. The important point about the light signaling system is the return on investment it can deliver to your practice. Typically, 30 to 60 minutes of wasted time per provider per day can be recovered. That translates to 2 to 3 more patients seen each day, 6 to 12% more time with each patient, or some combination of the two. We all know that you can't manage what you don't measure. Conversely, by measuring every stage of the patient flow life cycle and knowing exactly where the patient bottlenecks are occurring, tight management of patient flow becomes possible. Here's a case study. Six Sigma experts in healthcare normally equate each minute saved to $10 to $15 in revenue. The top end of the range is for a physician. The low end might be for a receptionist or other non-exempt employee. Here's what happened in one medical center in Georgia. We conducted a waste walk of the facility in November of 2014 and discovered that the average elapsed time from a patient walking in the door to exiting the facility was 73 minutes. We call that door-to-door measurement. We worked with them month to month and reduced that by 20% down to 59 minutes door-to-door. In just a year, they shaved a full 14 minutes off for every patient. One way to look at the impact is to realize that this resulted in each physician being able to see 2 to 3 more patients every day. For 5 doctors over 300 clinical days, that translated to over $200,000 in additional revenue. Expediter enabled this medical center to better manage the patient flow process by providing detailed measurements of it. You can manage what you do measure and get a robust ROI from it. In this second example, our goal was to help the clinic reduce patient turnaround time from exam room to exiting the facility from 50 minutes down to 45. We overshot the goal and got it down 36% to just 32 minutes. This clinic recovered a full 18 minutes of wasted time for every patient. It enabled them to see an additional 83 patients per month, and with the net revenue per visit at $118, their total revenue increased almost $10,000 per month, or about $120,000 annually. Again, you can manage what you do measure. We want you to be able to capture data at every stage of the patient life cycle. We've talked quite a bit about this notion of managing better by measuring better. In healthcare, just how important is measurement and then analysis of the data that's captured? To answer that question, let's follow the money. In 2015, $34.5 billion was spent on healthcare technology. In 2016, $66.5 billion will get invested. What's more compelling is the fact that 54% of that 2016 investment, or $36 billion, will go to analytics. That's more than the entire 2015 healthcare technology budget. Clearly, to a greater and greater extent, strategic decisions in healthcare will be made, must be made, based on hard empirical data. Here's a closer look at the 3 main areas on which that $36 billion is going to be spent: data capture, data provisioning, and data analysis. Data capture is the acquisition of data, of key performance indicators, or to use Lean Six Sigma terminology, KPIs. Data provisioning is the organization and translation of all that data. More simply stated, it's converting gigabytes of raw data into meaningful use data. Finally, the difficult, challenging, and most valuable part, data analysis. That is, interpreting and evaluating data, transforming it into information and insight, and determining meaningful steps that can be taken to eliminate all forms of waste from a clinical facility. The goal is to provide that discovery tool or business intelligence, a tool that will capture and provision the data seamlessly. The Expediter Patient Flow Efficiency Performance Monitoring Tool is Extract. It helps accomplish both of the two goals we set out to meet: decrease all wait times and improve patient satisfaction. By looking at all the data elements, we can get our arms around each of the key performance indicators or KPIs along the patient flow life cycle, from when the patient walks in the door to when they walk out the door. From when the patient checks in to when they are roomed is the waiting room time. Collecting waiting room time data can be a challenge. While EMRs are typically used to collect the check-in time, but not the time when the patient is roomed. Since waiting room time is considered by many to be the most important metric that leads to patient satisfaction or dissatisfaction, this is an important issue. The second KPI is patient wait time in the exam room. Getting a patient into an exam room marks the end of the waiting room time and the start of the exam room wait time. Upon entering the room, the physician uses the Expediter light signaling system to note the end of exam room wait time and the beginning of the doctor encounter time. The next KPI is marked when the doctor completes the patient encounter and presses the same button used at entry. This closes down the patient-doctor encounter time. If any ancillary service needs to see the patient, the respective lights dedicated to that ancillary service are pressed, and we begin to capture those wait and encounter times to measure efficiencies in ancillary services. The next KPI is doctor time between patients. This metric is particularly relevant. Frequently, doctors spend 10 to 11 minutes charting between patients. Managing this process with data and using a scribe to assist with charting can reduce this time to as little as 2 to 3 minutes. At this point, the patient is finished seeing everyone, walks to the checkout counter, and when that process is complete, the checkout administrator closes down the patient door-to-door visit time. At that point, a polite request almost always gets the patient to complete a very quick satisfaction survey. The survey results can provide profound information regarding the patient's perception of the visit versus the reality of the data that has been collected. The perception of a 45-minute wait might exist when, based on the data, we know that it was actually just 15 minutes. The perception of a patient is paramount to patient satisfaction scores going up or down. Simply asking them how we did today will give us a great insight and allow us to manage our patient flow process much more effectively. 50% compliance is not at all unusual, and that far exceeds any standard HCAP and CGCAP surveys, where a 10 to 15% return of mostly negative responses is common. So now let's discuss each stage of the door-to-door patient flow life cycle. Waiting room wait time. 24 minutes is the average waiting room time across the U.S. in all specialties. This graph, produced by Press Ganey, shows that at 10 minutes, patients start to get upset. Dissatisfaction sets in before they even get back into the clinical area. This is a difficult mountain to overcome back there. The goal we set for ourselves is to eventually get this wait time down to under 10 minutes. We work with the practice month in and month out to get there. We'll now take a look at how Expediter enables the capture, provisioning, and analysis of waiting room time data. The Extract module provides 3 views: a patient view, a receptionist view, and a nurse tech view. First is the patient view. This tool is web-based, so it can be viewed on any device that can access the local Wi-Fi and launch a browser. Patients simply walk up to a kiosk or tablet that sits on a counter at the receptionist window. Select the doctor they're seeing, type in their name and birth date, and choose their appointment time from a pull-down list specified by each doctor's schedule. Appointment times can easily be customized to show, for example, 5, 10, or 15-minute appointment intervals. When patients have completed check-in, they then go sit down and wait to be called back. Next is the receptionist view. The receptionist selects two buttons. Process, which means that the receptionist is processing paperwork on the patient, and the Ready button, which is clicked when the receptionist has completed all tasks and the patient is ready to have the nurse or tech escort them to the exam room. This list of all checked-in patients can easily be sorted by arrival time, doctor, or appointment time, simply by clicking the appropriate header tab. Next is the nurse or tech view. Up at the top, you can select by doctor to view all patients that are ready to be roomed for each doctor. Nurses typically work with one or two physicians, so they can see each doctor's patient list, or they can select View All and see all patients that need to be roomed in the practice. When a nurse or tech is ready to room the patient, they simply select Roomed and go get the patient. This closes the loop on the overall patient waiting room time. The next set of metrics is collected by the Expediter Lite system. By simply pressing buttons on actual or virtual monitors, we can see and know which exam room a patient is in and how long they've been there. We can also see the average time a doctor spends between patients, the doctor and ancillary patient encounter time, the checkout time, and the overall door-to-door visit time. Now let's look at the checkout process. The patient walks out of the exam room to the checkout counter, and the checkout employee simply selects the patient's name. Then, the patient is moved to another doctor or ancillary service, or if the patient is ready, simply select Checkout, and we've now collected the patient's door-to-door visit time. Now, we move to the short patient satisfaction survey. It's really incumbent upon everyone at the clinic, including the doctors, to promote filling out the survey prior to exiting the building so that we can get insight into that valuable patient perception. A polite request to take 30 seconds to fill out a very brief survey is usually all it takes. You can imagine the thousands of bits of data that need to be captured and provisioned. During every patient's visit, we collect each of the KPI timestamps so that we can know how we're doing from an overall patient flow standpoint and how well the perception of the patient matches up to the reality shown by the actual data. Month in, month out monitoring of this data is very important in maintaining great patient flow efficiency and great patient satisfaction. Month in, month out monitoring enables us to identify and eliminate bottlenecks and to continuously improve performance. The check-in to checkout tool produces a daily report that provides each patient's name and all the details on appointment, arrival, and checkout times, from when the patient checks in to when they check out. This data enables intelligent decision-making about actionable changes to be made to improve performance in your practice within 24 hours. The real-time monitor, shown here, provides insight into the current situation. It recycles every 30 seconds, so a practice can literally make actionable changes based on real-time data at any time during the day. This example is from an urgent care clinic. At the point in time shown, the wait time in the waiting room is long, but the total door-to-door time is reasonably good. The wait is long, but patients are treated quickly once they enter the clinical area. This is where the real-time data becomes really valuable. We can also port or move this data over to any other device for viewing. You could put it up on a monitor in your waiting room to begin managing patient expectations. You can also integrate it into your website, into an area that shows the current average wait time in a given facility. Again, an excellent means to manage patient expectations. We have access to very detailed granular data that can be reviewed at any time, all the way down to details of every patient visit and everything that transpired during that visit. The data is also viewed in a metrics dashboard for easy review of KPI data for the overall practice, as well as for doctors, nurse practitioners, nurses, assistants, and ancillary services. It is a highly interactive tool that provides insight into how the entire staff is performing. This slide shows the current door-to-door times for one of our clients. When we got started with them, door-to-door time for all physicians in the practice was well over their 60-minute target. In other words, all the bar graphs are red. Now on this slide, you can see that working with this client month in and month out, that consistent improvements were made across all practices. We are now exceeding our targets. When a practice creeps over that 60-minute target, we look at the data, identify and implement appropriate changes, and get them back under that goal. You can also click on each one of these facilities and see individual doctor data, along with that for nurse practitioners and ancillary services. Simply roll over top of each and you get overall averages, and once you click, it takes you down to the next level of data on each employee and how they're performing. This is where we can start using the data to help manage patient flow efficiency in the practice. What's the average check-in time? Wait time in the exam room, then the doctor time between patients, encounter time with patients, and the overall door-to-door time. We can also see if the doctors are using the light system correctly by reviewing the compliance thermometer on the right-hand side of the dashboard. It's an important metric. If you're 70% or better, this means we're getting very good data and data that can be used to make actionable changes. You can't manage what you don't measure, so we've got to be able to capture and provide meaningful data first and foremost, and then set our goals and continue to improve month to month. That's our competitive advantage. We not only capture and provide meaningful data, but we also analyze and consult with you on how you can improve. We've got a lot of green right now, and if you know anything about Lean Six Sigma scorecards, we like our green. It basically means we're reaching our goal. And if you know anything about human behavior, you also know that point-in-time measurement is good, but continual month-to-month measurement and monitoring is much, much better, because you know that as soon as you stop measuring, the bad traits of human behavior start creeping back into play. As we discussed, we look at this data monthly, and we reach out to each of the practices when we see the practice peak into the red, or frankly, even get close to it. At the end of each month, we begin pulling together your Lean Patient Flow Efficiency Scorecard. These scorecards are based upon Lean Six Sigma and Balanced Scorecard measuring, so both methodologies require the organization to rely on patient flow data at each stage of the patient flow lifecycle. Initially, our goal is to establish our site KPI goals. We've set data parameters for each KPI based upon many different resource leader sites such as MGMA and AGMA, specialty resource leaders like AAO, ASCRS, and AAFP to come up with KPI benchmarks so that each client can measure and see how they stack up to those KPIs each month. If a practice or institution reaches a green status in all of the KPIs, we feel they have reached a maximum level of patient flow efficiency. It doesn't mean that there's still not room to improve, but it does say they have reached their goals. Each client's specific numbers are logged in and scored green, yellow, or red based upon where the numbers fall. Once we've established our KPI goals and we have logged in all specific practice and staff times, we calculate the number of green, yellow, and red boxes and determine what our percentage of green, yellow, and red is currently. Most balanced scorecard scoring takes the top two boxes by adding the green and yellow percentages together to determine what their top two box score is. We feel that if we reach a top two box score of 85%, we have reached pretty darn near a maximum level of patient flow efficiency, because we contend that if we have a higher percentage of greens and yellows, we're hitting our individual KPI goals along the way. You can see in this client example that we began measuring patient flow efficiency in 2014. At that time, the top two box score was 70%. In 2015, it was 71%. Slight improvement, but as you can see, we added 8 more practices to the mix. In first quarter of 2016, we have already improved our top two box score to 77% and are slowly but surely getting closer and closer to that 85% efficiency goal. So a recap: 70% in 2014, a slight improvement to 71% in 2015, and a big jump to 77% in just the first quarter of 2016. The hard work is paying off. So that's our story. Our job at Expediter is to capture data, to provision data, and most importantly, to analyze data, then consult with each facility to maximize patient flow efficiency. By applying lean management principles to increase efficiency in patient flow, we can help deliver better quality of care and higher patient satisfaction. We typically are able to recover 30 to 60 minutes of wasted time per provider per day, which enables seeing 2 to 3 more patients, spend 6 to 12% more time with each patient, or some combination of the two. Thanks for listening. To get more information about how to streamline and optimize your patient flow, visit our website at expediter.com or give us a call at 1-800-843-9651.